Boa tarde a todos. Estamos aqui reunidos na medida do possível para fazer um webinar sobre a resposta da medicina intensiva à epidemia por Covid-19 e para partilhar a experiência italiana. Primeiro do que tudo, queria apresentar as pessoas que vão estar a fazer este webinar, nomeadamente o professor José Artur Paiva, do Colégio da Ordem dos Médicos de Medicina Intensiva, o Dr. Filipe Froes e o professor Tommaso Mauri, de Milão, que nos vai contar a experiência italiana. Italy and especially Lombardy are devastated by this new disease. Our thoughts are with everyone in Italy, so I'd like first of all to thank you, Tommaso, for your time and your kindness to be here with us, just sharing your experience and expertise. Thank you.
Thank you. So, shall I start?
I think that we'll start with the Filipe Froes, who will just tell us the new directions from Portugal regarding this disease, and then you'll tell us your experience.
Ok, podemos começar então. Pode pôr o primeiro slide então. Bom dia, boa tarde a todos. Eu vou tentar ser breve, vocês não estão aqui para me ouvirem, estão aqui para ouvir e partilhar da experiência italiana, mas de qualquer maneira está a ser anunciada uma nova norma e era preciso, pareceu-me fundamental, explicar o racional clínico que está na base da nova norma. O racional clínico que está na base da nova norma foi elaborado por uma equipa que além de mim inclui o António Diniz, o Fernando Maltês do Curri, a Maria João Brito da Estefânia e a Margarida Tavares do São João. Próximo. Isto só para dizer, próximo slide. Portanto, isto é o sétimo, como vocês sabem, o sétimo coronavírus. O coronavírus tem aquela forma de uma bola especulada com uma coroa ao microscópio eletrónico, daí coronavírus. Ele tem cerca de 60 a 140 nanómetros, 30 mil bases. Esta é a sétima estirpe a afetar o homem, 4 delas são responsáveis, são perfeitamente banais, por 15 a 30% das constipações na idade adulta e pediátrica. Na fotografia de cima vem um dado extremamente importante, que é a glicoproteína S, que é responsável pela entrada na célula através dos receptores ACE2. Nós sabemos a localização destes receptores, localizam-se no pulmão profundo, sobretudo nos alveolocitos, também se localizam no aparelho digestivo, também se localizam no rim, mas temos aqui uma particularidade. Com a idade, por cada década de vida, há um aumento de cerca de 20% dos receptores, o que poderá explicar uma maior prevalência e uma maior gravidade na população mais idosa. Próximo slide. Para onde vamos? Covadis, Covid-19, é esta a pergunta do slide. Vamos para uma tentativa de mitigação. E a tentativa de mitigação, não sei se está a ver o slide. Está a ver o slide? Oh, estás a ver o slide? Portanto, tem uma curva azul em que o que se pretende é precisamente diminuir a área debaixo da curva e diferir ao longo do tempo as necessidades. Nós não temos capacidade de tratar, se calhar, 200 doentes críticos em poucos dias, mas se conseguirmos diferir esses 200 doentes críticos em cerca de 2, 3 semanas, a probabilidade é maior. Muitas vezes perguntam se nós estamos em mitigação, porque é que ainda temos estas medidas de contenção, porque a fase de mitigação foi desenvolvida para a gripe e percebeu-se que esta situação é mais grave do que a gripe e a mitigação, para ter resultados, obriga a manter fortes medidas de contenção. Nós temos que perceber que o vírus faz aquilo que é suposto fazer, ele não varia, embora possa haver alguns esqueletos e algumas mutações, ele faz sempre o mesmo, entrar, replicar, sair. Nós é que temos que fazer o nosso trabalho. E o nosso trabalho tem que se basear em combater não só esse vírus, mas um outro vírus muito mais importante, o vírus dos 3 Is. O vírus da ignorância, da impreparação e da inadequação. Próximo slide. E temos aqui o esquema da abordagem. O esquema baseia-se no conceito 80-15-5, em que 80% dos doentes têm formas muito ligeiras de doença, podem seguir perfeitamente em ambulatório. Aqui é fundamental informar e formar as pessoas, garantir a adesão às medidas. Alguns deles vão estar em vigilância ativa ou autovigilância. Temos que identificar e ter capacidade de identificação precoce da gravidade, e aqui os testes têm uma importância muito grande, quer em termos epidemiológicos e em termos de identificar os doentes que estão a transmitir na comunidade e colocar essas pessoas em contenção e distanciamento social. Depois temos o grupo dos 15% internados em enfermaria e temos o grosso do trabalho nos 5% internados em cuidados intensivos. E nós aqui é onde nós temos que concentrar os nossos recursos, temos que confirmar o diagnóstico em todos, o que significa que temos que testar todos os doentes, até que queremos criar zonas dedicadas, são as chamadas ADC, áreas dedicadas ao Covid, para separar os doentes Covid dos outros doentes para os quais as patologias continuam a existir, porque as outras doenças continuam. Temos que tentar identificar formas de tratamento de todos estes doentes, até para, com alguns fármacos imunomoduladores, reduzir a potencial evolução para formas graves. Temos que garantir a proteção dos profissionais de saúde, que é um aspecto crítico, e envolver as sociedades científicas, e por isso é que a Sociedade de Cuidados Intensivos tem tido um papel essencial. E isto tem que ter uma coordenação central. Próximo slide. Tem aqui agora o esquema da primeira fase, com base nos critérios de rastreio sintomático, febre, tosse ou falta de ar, já um bocadinho mais afinados. Com base nesta nova estrutura, a linha de apoio médico desaparece, a entrada será pela linha de saúde 24, que terá capacidade, logo através da estratificação da gravidade, de enviar alguns doentes para o ambulatório, onde eventualmente poder-se-á fazer testes em ambulatório, e outros doentes que necessitam de investigação mais profunda ou com eventuais critérios de gravidade são enviados para os serviços de urgência Covid, que também se chama Covidários. E aqui nós temos dois grandes braços, sem critérios de gravidade e vão para o ambulatório, que é o chamado Covid Casa, ou com critérios de gravidade, e aqui estes doentes com critérios de gravidade entrarão num circuito próprio, que será a enfermaria Covid, ou se agravarem, o CI Covid. Foram também desenvolvidos critérios quer de detecção precoce de agravamento, quer de alta precoce, de maneira a libertar camas. E temos critérios de cura. Próximo slide, para acabar. No próximo slide, nós temos já numa segunda fase, onde poderemos abdicar dos testes de escala, porque não temos testes, e temos que concentrar os recursos na identificação das formas graves para manter as áreas dedicadas, e temos então, de uma forma muito clara, testes só nos doentes internados e assegurar as duas áreas dedicadas. Portanto, foram desenvolvidos testes, critérios para a elaboração de testes, critérios de gravidade, critérios de alta precoce, critérios de monitorização em ambulatório. E o último slide, próximo slide, estão aqui os critérios que vão ser apresentados na norma. Então, a norma inclui critérios de pediatria, porque estão conjuntos. Foi também solicitada a colaboração da Sociedade de Cuidados Intensivos e deste grupo de trabalho para desenvolver um score que permita distinguir entre pneumonia Covid e não Covid. E, para terminar e dar a palavra à pessoa mais desejada, apresento então o último slide, que, a meu ver, sintetiza bem o ponto de situação onde nós estamos em relação ao boletim epidemiológico. Nós, neste momento, à data de hoje, temos 2060 doentes, provavelmente temos mais, estes são os casos confirmados. Temos 23 óbitos, que em relação aos casos confirmados representa uma taxa de mortalidade muito inicial de 1,1%, com 201 doentes já internados em enfermaria. Estes são os grupos do 80, 15, 5, portanto não temos 15, temos 10, mas provavelmente caminharemos para os 15, e temos 2,3% já em cuidados intensivos, que representa 47. É do nosso esforço, de todos, dos profissionais de saúde e da população, que nós pretendemos diminuir esta curva ascendente que se aproxima. Eu depois estou à vossa inteira disposição para dúvidas. Muito obrigado.
Artur?
Still starting to know how to deal with this. I'm sorry. Tommaso, it's a pleasure for us to be here with you. We've been listening to reports and news and papers regarding your enormous fight in Italy against the virus, and congrats for your enormous fight and your solidarity. I mean, we are here really to listen to you, and I'm sure that in the end we'll be able to put you some questions about your presentation or your conversation. Thanks very much, Tommaso.
Tommaso?
Oh, sorry. So, can you see my slide?
Yes, everything okay?
Okay. Thanks. Sorry, I was on mute. So I start sharing a few numbers from this outbreak in Lombardy region. Lombardy was really the start, the place where it started around a month ago. And here are the numbers. So if you see here, This is the 25th of February, and this is 20th of March, so 3 days ago is updated. And you see that this is the surge in patients with COVID-19 only in the ICUs. And you have to keep in mind that 93% of these patients now are intubated. So from the very beginning, going to the ICU means being intubated. So this is not average ICU population. It's a very severe ICU population, because those needing high flow nasal cannula or CPAP or non-invasive ventilation, they stay out of the ICU because there are too few beds. We can admit only those intubated. So you see that here, if we look at the beginning of March, which means 3 weeks ago, you have 149 patients, and now we have 1,200 patients. So in 3 weeks, the number of patients became 10 times higher. And I was told that you are around here. I really hope for you that you don't arrive here. But this is the kind of surge that you can have in less than 3 weeks, in less than a month. And these are the number of ICU beds. You see the column right next to the blue, to the light blue, the orange one, I would say. And you see that you need to create new beds. So every day there is a jump, you see. So every day we opened new beds because we needed for new patients. And this means that this was the first point. You have to think as a network from the very beginning. In my hospital, which is in the very center, city center of Milan, near the Duomo, we admitted for I would say the first 2 weeks, only patients from outside Milan, where there were the big focus of the start of the infections. That was south of Lombardy region, Lodi, Cremona, and Codogno, it's in the news, and now Bergamo. So really, we could cope with this incredible number of patients intubated, only because we started reasoning and facing this surge as a network from the very beginning. There was, since the very first days, a centralized telephone number that every hospital in Lombardy knew, and you could call at any time during the day or the night, asking for an ICU bed for your patient. So as soon as you intubated the patient, you could call and ask, where is my ICU bed? And someone will organize transportation and organize the ICU bed in another hospital, most likely. This was the hugest effort here. Also because transportation needs to be careful, because you don't want to spread the virus, because all the people, normal people, are inside their homes, they are locked in, while patients move around the region. So you don't want to spread the virus with the patient. Indeed, the other main point that you have to think about very early is the safety of the staff. In the beginning, we were not so prepared, and there were many staff that got sick. And so even if you don't have yet your COVID patient there, I think you have to think about places inside the hospital where they are clearly divided and where you get in only with your individual protection devices. Because the staff is not only that you get sick and you lose staff, but also that if you move patient from one town to the other and the staff get sick, it means that the virus is going from one town to the other, from one city to the other. So you want to move the patient to keep them alive, because they need a ventilator and ICU bed, but you don't want to move the virus. what kind of patient we are admitting. So most are male. So this is a very new syndrome for us. You will tell us when you will have your patient, but it's not a severe bilateral pneumonia from viral origin, from viral etiology requiring intubation. It's not the average is not average ARDS, even though they fulfill the clinical criteria for ARDS. But we will speak about this in a moment. So it's a strange disease. Mostly are male, the one that are in the ICU. Remember, intubated 93%. You see that ECMO is performed only in 7 patients and prone position in 16% of patients. This has 2 main reasons. These few patients are rescued with ECMO or prone position. First of all, it's very, very, very demanding to take care of this patient inside the ICU because you are all dressed with your, we have a mask, we have glasses, we have cap, you have gown, you have 2 or 3 pair of gloves inside, and you stay inside sometimes 4, 5, 6 hours. I don't know if you can see my nose. This is the mask sign. So especially for the nursing staff, it's very demanding. So you have to keep the ICU and the care of this patient the simplest as possible. So you have to be sure to do the essentials to care for this patient. And we limit prone position only to rescue. So, for example, PF below 100 or even below 80. And ECMO, I think, is not feasible by now. These ECMO patients were really rescue of very, very young patients who were dying from severe hypoxemia. And it was done at the very end as a desperate measure. And we had one of the ECMO patients died in my ICU 2 days in our ICU in Milan 2 days ago because of multiple organ failure after around 1 week of ECMO. But he was 37-year old and he was perfectly healthy before. So that was really a desperate maneuver, but I don't think ECMO is feasible in this context. A few other words on the patient. So these are not only very old patients with comorbidities. There are a lot of younger patients. You see here, this is the population that was admitted, intubated to the ICU. Half of the patients are younger than 63 because median age is 63 and 25% are younger than 56. We have from 14 to 91. 91 was in the very beginning where we didn't know where we were going. Now I would say that I would think about intubating a very old patient like above 80 or 85 3 times, but we don't have any rule not to intubate older people. This is not true. It was written in the newspapers. Also because people who study and doctors who have experience know that frailty is the most important assessment in the decision of the priority for patient, and it's not linearly correlated with age. It's very important to assess the quality of life and the independence of these people on top, in addition to the age. However, there are a lot of younger patients with very few comorbidities. And here I can show you very preliminary data on the mortality, because one other aspect is that the duration of the intubation and the ICU length of stay, you have to be prepared that is long. Indeed, most of the patients you see here are still in the ICU. More than 1,000 are still in the ICU. we had 362 deaths and 280 discharged alive by now. So by now, the mortality is higher than 50%, but that's very, 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 very initial and pilot data. I don't think these are reliable yet, because yes, we have this tremendous amount of people still in the ICU. But it's true that even for patients that are less hypoxemic from the beginning, the number of ventilation of intubation days can be long. I guess my feeling is that it will be more around 10 days, the average, than 1 week. Because it's my guess is that we have supported treatment. We intubate, ventilate, feed them, but we don't have the specific treatment. There are a few, I call them magical pills, some antivirals, some modulators of inflammation. Each center and each infective specialist, infectious disease specialist in each has his own modulator, anti-IL-1, anti-IL-6. Then we have someone using methylprednisolone after the data from the Chinese. I don't know. The data are too few to say what is effective. But these are the only specific treatments that we have, and they are very little specific. So I guess that instead, if you have a ARDS in the normal days, you have supportive, but you also have 80% will have pneumonia, and they will get their antibiotics. So the average ventilation days is around 7 days for a ARDS. Here, I think you should be prepared. We are seeing around 10 to 12 days of intubation as an average, because even for those who survive, is very slow, the recovery. So from a organizational point of view, for the region, these are the numbers. People around the world are saying that we were a little slow in closing, and now everybody is closing all the schools and the work and much before the NAS. I don't know. Nobody knows if that was the reason. Right now, we are all closed in our houses, and it's very effective. There is nobody around. I go to work tonight. I will go to the ICU, and around the city, you see only soldiers with checkpoints, and at the train station, you see only soldiers. There is really nobody around playing or running or taking out the dog. We are all inside their houses, and we really hope this will be effective. But the surge has been impressive. So the key points I would say is to reason as a network from the beginning, to be safe and to protect your staff from the very beginning. Don't spread the virus by sending around the patients. And a few hospitals remain for non-COVID patients. This is important to be centralized too, because people will still have acute myocardial infarction, we still have some trauma. I'm not talking about elective surgery, but some ICU beds should be kept for non-COVID patients with needing acute treatment, and this should be centralized too, should be in the network. And think about this, and all the people that don't have to do essential work should stay home from the very beginning. This should be really something that people understand before there is a law, before there is the soldiers around the streets. We need to be careful from the very beginning. So this will be the part on, if you have any question, I don't know.
I think we've got lots of questions. I've been receiving several WhatsApps, and I already have some questions concerning this part. I think that it's we already had some experience with the personal protective equipment, and it's really very hard to work with it. It's hot. It takes a lot of time to put on and to take off, and people are very concerned that maybe you don't have enough for the time that we will have this disease. But how did you manage the healthcare personnel? Did any change in the patterns of work? Do you have a 12-hour shift, 8-hour shift?
It's so I speak only for the ICU. I don't work in the emergency department. I don't know exactly how the regular wards are organized. If you are for example, my ICU is 12 beds, all intubated with COVID-19, and all the least FiO2 when they get in is 50%. So I would say moderate severe ARDS patient with COVID-19. So that is very, very demanding. So each patient changes. You have to reassess the patient every 2-3 hours sometimes. You have to do bronchoscopy. You have to prone 3 or 4 patients in the very beginning sometimes because they are dying by hypoxemia. My personal experience is that after 4 or 5 hours, it's dangerous to keep staying inside. It's dangerous. So I think you should be, we are organized that every 4 or 5 hours we go out. There is always someone inside, always one doctor at least. Then we have residents because we are an academic hospital, but even in because if you need to change and there is an emergency, that could be too late. So you need to have a doctor inside. But I think that it's better to have a fresh doctor, single one, than 2 doctors that are tired, who are tired. So because keeping your mind active and ready to respond to emergency is the one of the most important thing, because the changes from a clinical point of view instead are very few. You set a PEEP, you ventilate, you set your magic pills, you give some nutrition, you check the food balance, and that's it. You prevent deep venous thrombosis and stress ulcer prophylaxis. These are from a clinical medical point of view, these are quite simple patients. Once you set them the therapy from the beginning, but you have a lot of emergencies, a lot of patients desaturating, a lot of patients increasing the PCO2 because they are over distended, and so you have to be prepared and not to be too tired being inside. So I would suggest to make shift. For example, overnight in my ICU we are 2, and we do 6 hours, but we do 4 hours, 4 hours, then 2 hours, then 2 hours. Some other colleagues do 3 hours, 3 hours, 3 hours. The downside of this is the number of the individual protection devices that you use. That is true. We try to limit them as few. We don't reuse them for sure, but that's an issue. You have to be prepared. But I think that the good care for this patient means rested and alert and awake doctors, much more than a lot of doctors inside. This is our approach by now.
Tommaso, a question. How many of those patients needed renal replacement therapy?
Okay, so I don't have the numbers exactly. I can tell you our experience in my unit. Out of 12 beds, we only have 2 machines, 2 for continuous venous filtration and dialysis. So, and by now we had only once the machine was used, the device was used on one patient for a couple of days, then the next patient for the other couple of days. So By now, we have 3 out of 12 needing that. My feeling, it's really a gut feeling from a clinical point of view, is that if you use too high PEEP level and they don't need it, they are at high risk of developing renal failure. The second reason for renal failure is severity. So those entering the ICU with already some renal failure, I would say these are very severe, because the course of the disease has already gone far, let's say. So I would say that less than 20% might need that if they are treated properly. And once they arrive to dialysis, those become very severe patients, and you have to decide what to do.
Okay. Tommaso, can you hear me? Yes.
Yes.
Right. So still regarding the organization area, in my hospital, we now have 24 patients in intensive care with COVID-19.
Mm-hmm.
And still there are really two different populations. You have the old person with some comorbidities that you would go to hydronasal cannula or some non-invasive ventilation, but you would not go upwards regarding care. And you have the very, very severely ill that has to be intubated and invasively ventilated very, very quickly. And after the intubation, he stays for 1 or 2 hours very, 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 very unstable, although afterwards it stabilizes. Regarding the organization, as you told us, I think it's very important. You really have to dedicate level 3 care, intensive care, to the very severe patient. Has your hospital organized a level 1, level 2 unit for the other segment of patients? First question, does that area contain the patient I have described, the old comorbid patient, but also the step-down patient from your unit when they recover and improve?
Yes. The hospital has become, so I would say that all the ICUs, even in the smaller hospital, are level 3, as you say, so accept only intubated patients. So all hospitals in all hospitals, there are patients managed on non-invasive ventilation. We use a lot helmet CPAP. High-flow nasal cannula, people are not so confident to use because of the risk of spreading the virus around. So I would say mostly will be on non-invasive ventilation or CPAP in what used to be regular wards. Patient needing just oxygen, they are kept like in the emergency department. They are the smaller part in the hospital. If you need some oxygen, as soon as you recover a couple of days, you are sent home. So so these units, step down, are mostly run by pulmonary pneumologists, cardiologists, internal medicine, emergency department physician. And we had a lot of very fast but effective training for figures that are now not doing much in the hospital, like surgeons. So they are trained on some specific how to set oxygen, how to set a CPAP, how to set a non-ventilation, and when to call. That's the most important. I think that the message should be intubation early, especially for younger patients. Failing non-invasive ventilation, it's a disaster in this patient. So the patient staying with high FiO2 on non-invasive ventilation for 1, 2, 3 days and younger, I will be very careful and intubate early. As soon as the PF is below 100 and the respiratory rate is above 25, something like that. But we have to be careful in this sense, especially with the younger patients. We don't have anymore in the ICU very old patient with a lot of comorbidities intubated. Now it's impossible.
Another question and doubt that actually we've been discussing a lot this morning in my service is the role of antibacterials. I mean, how do you deal? What's your strategy regarding the diagnosis of co-infection and the super-infection? And how do you deal with antibacterials?
So we don't start antibacterials right away. The hypothesis is that all the patients only have COVID until there is evidence of the contrary. So if you don't have an isolation, if you don't have positive urinary antigens for co-infection from the beginning, we don't start antibacterial. Then this is normal care in my unit. We do surveillance cultures because fever is there and inflammation is there. So it's impossible to diagnose, I think, a co-infection or super-infection without a surveillance cultures. Then the other thing that we use is procalcitonin, because usually these patients have low procalcitonin if they are only COVID. So that gives you at variance from other inflammatory index some guidance. Once we have the positive, for example, bronchial secretions that are surveillance are positive, we reason with the infectious disease specialist if that is really a super infection and needs to be treated. I would say that by now we had a lot of staph super infection, a few multi-drug resistant, sometimes simple super infection. Also because we give this immunomodulator. In my unit, we only give
tocilizumab.
No, not tocilizumab. We are thinking about starting a trial for that, maybe a centralized larger trial. But we now giving anti-IL-1. It's called anakinra. But to very selected patients, and there is a specialist from the immunology department coming every day. Not to everybody, I would say less than half, with specific criteria. They have to be hyperinflamed with very high ferritin levels, with very high C-reactive protein levels, and they don't have to be too severe, no renal failure, no hemodynamic instability. So some criteria, and you have to be careful. But since we are giving those, and we used in the beginning some methylprednisolone in those hyperinflamed, but we don't know, because there is some evidence that in H1N1 corticosteroids were dangerous, so nobody really knows. However, there are our feeling is that those hyperinflamed, a lot of fever, a lot of C-reactive protein, very high ferritin, those are the most difficult patients. That takes longer to recover from the hypoxemia and in those we use, as I said, surveillance cultures.
Tommaso, just the one last question regarding organization. How did you increase your ICU capacity? Did you expand to other areas? Which areas? How did you manage from the physical point of view?
So physical point of view, the simplest is that you decide from the very beginning, some hospitals become only COVID, and you keep a few spots in other hospital with your as ICU, as normal ICU. Also because having a ICU split in half is very difficult. Instead, if you have a full ICU, only COVID, it's simpler also from a logistical point of view, because you enter from one side, you exit from the other, and you cannot mix. So the ideal, I think, is to start from the very beginning, having a full dedicated ICU for COVID and another one not. After, if you arrive to our situation where we needed to expand the ICU bed by around 50%, yes, we looked for other places in the hospitals and turned normal rooms into fully equipped ICUs. You need to have. We selected where we had the gas from the wall, and we bought ventilators. We are lucky that we are not using operating room ventilators by now in my hospital. There is a lot of generosity, a lot of people donating, and we managed to have only ICU ventilators for all the patients. But for example, in my hospital, there were around 30 regular ICU beds. Now, only for COVID patients, we are arriving to 50. And then there is still the pediatric ICU and a small non-COVID ICU for surgical patients and neuro patients. So yes, I will start from full ICUs and look for other places in the hospital. You need to have some, for example, we don't perform CT scans unless it's life-saving, unless you have a bleeding patient. We don't use them routinely. So whenever in the hospital is okay, in a sense, because you keep that inside there and you bring all your diagnostics there.
Okay, thanks.
Could I ask another question? Tommaso, something that has puzzled me in your data is that you only used 16% of the cases prone positioning. Does this mean that most of your hypoxemic cases are dry lungs, meaning they are much more, hypoxemia is much more due to vasoconstriction and to vascular aspect than actually to a leaky lung?
Okay, there is a huge debate ongoing all over the world. I'm in a mailing list of people from all over the world. From a physiological point of view, these patients are very complex. I would say that what we understood up to now is that I think that it's quite clear that they have a very almost normal, they have a dissociation between mechanics and gas exchange. So it's very common to have a patient with normal compliance, low driving pressure, and severely hypoxemic, and with a very high minute ventilation to keep normal PCO2. This is a quite diffuse findings in all, and this I think could mean we did measure ventilation and perfusion in 7 to 10 patients with electrical impedance tomography. We submitted this now, and there is a huge mismatch. And I think this is specific to this syndrome, because usually mismatch in RDS is due either to edema, the shunt, or to over-distension, you could say, that space. Instead, here, I think you have even a lower PEEP, you have compliance around 45. Average compliance in our patient was 47 at 5 of PEEP, and average PF ratio was 80. That's very strange. That means that the gas exchange alterations may not come from the classic model of alveolar flooding with edema that responds to proning. This is what I'm coming to your question. But it's more, and to high PEEP, but it's more a dissociation between the ventilation and perfusion. So the hypotheses are that that space is increased in this patient because of microthrombosis. there is there are some data showing that D dimers that are elevated are correlated with mortality. And there are a lot of reports around the world of CT scans where you have large vessels, where you have pulmonary embolism, which is not embolism, but it's local thrombosis by inflammation. And the dose of anticoagulants are increased in our unit, but also around the world. There are people fully anticoagulating them. We are not doing that because we don't think that anticoagulation is the solution for inflammatory thrombosis. But for sure, there is a need for a little higher level of anticoagulation even to prevent thrombosis. And instead, the hypoxic part probably comes to lack of effective pulmonary hypoxic vasoconstriction. So if these are the main mechanisms, thrombosis and lack of pulmonary hypoxic vasoconstriction, then the classic ARDS intervention that are high PEEP and proning for PF less than 100 most of the time are not effective. So I'm not saying you should not try high PEEP and proning. I'm saying that you have to be prepared that there will be patients very severe that don't answer to this. We do have patients obese with PF less than 100 on 10 of PEEP. Because if you increase, you go to 15, to 17, 18, the PCO2 will become one patient, more than one patient, 2 or 3 patients went to 100 of PCO2 if you keep a protective tidal volume. So my approach will be careful. I will start with PEEP around 10 to 14. And in those most severe, test each intervention. So if you test higher PEEP, test also something lower. If you test prone position, be ready to turn the patient back supine after 3 hours because PCO2 went to 120. This happened too. And also those who respond to prone position, it happened that some, after you turn them supine, they lose everything. And so given the burden of and the intensity of the care, where you think twice if to prone them again, because if you, and these going back to supine and the previous gas exchange fits with the model of ventilation perfusion mismatch as the main driver of the altered exercise. However, there is variability, so it's not one side fits all the patients. So, but these are some thoughts that already came to us in exchanging experience. Sorry.
On that rationale that mismatch, do you have any experience with nitric oxide or any kind of those drugs that deal with the vascular side, the perfusion side?
Yes. As a step-up approach, I can tell you last Saturday, there was this obese, very severe patient, 53-year-old, and he was getting more and more hypoxemic. And we tried higher PEEP, didn't work. We tried NO, second step, and didn't work. We put him prone, and he died prone. That was nothing answer to. However, I will try NO maybe before proning because it's less work, is less consuming, and there is a rationale. But it depends. It can work or may work or may not. But I will think about trying before proning in the most hypoxemic.
Yeah. Just one more question regarding the nurse team. Do you have any special nurse team for COVID, or do they work in different units, COVID and non-COVID?
No, okay. So personnel for COVID is dedicated. So once you work in the COVID, you work only there. And I think this is very important because there are some procedures that are not easy. and different from usual care. So if you change every day, it's hard. But we had to hire and to bring the staff from all over the hospital to the ICU. There are nurses that used to work in ambulatory care, now working in the ICU because we don't have enough personnel. So they are dedicated, but some they have very little experience with ICU, and you should follow them and be very close, and especially doctors should learn to help them perform an ABG, look at the patient, help them in turning the patient, in cleaning the patient, because it's a lot of work for them, really. We have a ratio of 1 to 2. We try to keep one nurse for 2 patients, even now, but also with very non-experienced nurses now, but very dedicated and generous, but just they never did the ICU before.
Okay.
Tommaso, a simple question. Do you have any experience with lopinavir, ritonavir, and chloroquine?
Yes. So we started with the Caletra.
Yes.
Now there is a study that came out, I think, in the New England that shows no benefits. I don't think that's a very, very, very definitive study, but it's already something, and it has a lot of interactions with sedatives, with other drugs, and it has a lot of, it can give a lot of problem on the liver. So I would say we almost stopped giving it, the Caletra. We gave it in the beginning, but now I would say less than 30% receives it. And instead, hydroxychloroquine, we use it because at least if it's not effective, doesn't have much side effects. And so we give it
with azithromycin or in monotherapy?
Monotherapy. But really, I think that nobody really knows what is the most effective. That's why I said that each patient has some magical potion. But it's very difficult. Some has hydroxychloroquine only, some with anakinra. We use remdesivir. We use remdesivir in selected patients, not too sick, and with the indications. And it comes for personal use with the name of the patient and through the ethical committee of the hospital, so not for all the patients. I think this is, it's very important to have a close collaboration with all the specialists from the hospital. So we work in close contact with the infective disease and the immunology specialists. They come to the ICU every day and we look at patients. Also because some of these drugs are anti-inflammatory, modulate inflammation, and you have also be careful and stop them once the patient gets super infected, for example.
Okay.
I have another question for those patients that are very, very ill. I mean, you don't seem to believe in ECMO and extracorporeal systems, Tommaso, but I mean, Italy has a great experience with even cytokine adsorption membranes, at least in Rome with Massimo and his group, a lot of experience. How do you feel with the extracorporeal systems in this cytokine storm kind of
we used it. Our approach is now that, as I told you, we have only 2 machines in my ICU for 12 beds for dialysis. So the first, and the patients developing acute renal failure are more severe. So our approach is pragmatical. So we first start dialysis because of acute renal failure. And once they have it on, we also try cytosorb. That's what you were referring to. I think all the 3 patients last week that received dialysis received a cycle of death too for overnight. I don't want to say anything, but it didn't seem very effective. But this is very, very, very experience-based with no clear scientific data. It's just our feeling, talking with my colleagues and our group. We don't feel that's life-saving. But once the patient has on dialysis on, I will try. ECMO, if you would come to my ICU in these days, you would think that ECMO is impossible. It's too much. I agreed with my colleagues who put ECMO last week in this patient, 37-year-old, who was dying by saturation was lower than 50 with 100% FiO2 and 15 of PEEP, and they started VV ECMO, and he died yesterday. It's not that because he died, but the amount of work that the nurse is really too much. So I will think about it 3 times. It's not standard. Should not be standard for all the very severe patients. One last thing, because then I'm sorry, but I don't have much time yet. One last thing is when you switch them to assisted ventilation.
Yeah, breathing. Yeah, that was what I was going to ask you.
Exactly, because I think there are 2 or 3 problems there. So our approach is like this. As they are very inflamed with a lot of inflammation, even though the gas exchange are not so bad, they are improving, they might have a very high inspiratory effort and difficult to control even with drugs and with setting. So we are very careful with the switch to assisted ventilation. We don't look only at the classical signs like high compliance, because they have high compliance from the beginning, FiO2 and PEEP, but also to the blood exams, to the blood chemistry. If the patient has 50% FiO2, 12 of PEEP, and in a sense recovering, but the inflammation is still very high, we wait and we are very careful in switching to assisted ventilation, because we have already seen a few patients switching to assisted ventilation, but that failed it.
It's 18 hours.
The other suggestion or experience that we have is on the opposite side. Since there is this mismatch between ventilation and perfusion, these are anecdotal, but it's the experience that we have. I have in mind 2 or 3 patients who even though they had very high FiO2, switched to assisted ventilation made them improve a lot. So, but they were not inflamed. So the first criteria I would use to decide whether the patient is ready to enter weaning is a clear decrease in the inflammation signs. And those who have these criteria, even though they are still quite sick from a respiratory point of view, might improve with assisted ventilation, because using the diaphragm better matches the ventilation and perfusion, especially in the dorsal part of the lung. And this patient was switched from, she was on 70% FiO2, still to have, and in 2 or 3 days it went down to 40% on pressure support. But really, she was not already highly inflamed. I don't know if this is clear, but this is our experience by now. We use PO1. It's very simple, and even all the ventilators have it. It's very simple to measure. If PO1 is too high, and the respiratory rate is too high, and this patient looks, the mechanics of the patient looks very bad, like thoraco-abdominal synchrony, we switch back to control ventilation and wait.
Okay.
You have to be patient with these patients.
Mm-hmm. it's just some last questions. And do you tracheostomize these patients? If so, when?
By now, we didn't do much. Other centers do it much more often. The problem is that it's very difficult to perform complex procedures because of the dressing, because of the instability of the patient. Because to tracheostomize a patient, you need 2 doctors for at least, even if you are very lucky, 20 minutes, half an hour. And you might not have that time and that number of doctors. So I don't think it's a question on physiology, on clinical care, but it's mostly an organizational question, whether to tracheostomize this patient. And we tend not to do because we don't have enough personnel, I would say, even though we have. So I think that a patient who is clearly improving and still needs some more ventilation days and maybe at COPD as an history, I would think about it. But average patient, we have physiotherapists coming every day in the unit, sometimes twice per day. I think that's, for the weaning part, it's much more relevant than tracheostomy. But it's mostly a matter of procedure rather than clinical decision.
One last question, because I mean, you have a wonderful experience with non-invasive ventilation, especially helmet interface. How do you avoid VLE? How do you avoid lung injury induced by non-invasive ventilation? What special care do you take? What pressure do you use? How do you deal with that?
So as I said, it's difficult to say now because those patients are not in the ICU. So you have to keep it simple. I would say that a patient who is not improving in terms of FiO2 needed after 1 or 2 days is a patient at high risk of developing injury and psyllia, I would say. You have to give simple measures to the ward doctors now. This is what we do. So if the patient keeps the same PEEP levels, same respiratory rate, and same FiO2 for 1-2 days, that's a very bad sign, in my opinion. I don't think we can have much more refined index. Like I would use FiO2 and respiratory rate. The ROX index that my friend Oriol Roca published, I think it's a valuable addition for non-specialized wards.
Okay. Tommaso, I know that you have to go.
Yeah, I have to take
You'll be on shift tonight. So I just want to thank you once again for your time and for your kindness to be here with us, sharing your experience. And I wish you all the luck and hope that it's going to work well for us too. Thank you.
Thank you very much. Stay strong, and I hope to see you soon in Lisbon, in face.
Thank you.
Grazie.
Thank you. Grazie.
We need to come back and meet each other.
Okay. Thank you, Tommaso.
Thank you very much. Bye. Bye. It was great.
Então, depois desta experiência, da partilha de experiência com o professor Tommaso Mauri, acho que nos cabe fazer um bocadinho o resumo do que aqui foi dito, e eu passava a palavra ao Zé Artur para nos dar a sua opinião do que acha que é importante nós retermos desta experiência italiana. Estás em mute, Zé Artur, não te ouvimos.
Dizia que talvez pudéssemos dividir nos aspectos organizativos e nos aspectos de cuidados e de terapêutica. Os aspectos organizativos, eu acho que há mensagens muito importantes. A primeira delas é que temos que ativar todas as camas de medicina intensiva que estão ainda inativas, se é que ainda estão, e temos que expandir o número de camas de medicina intensivas, porque o aumento da procura relacionada com estes doentes vai ser não só grande, como ter um crescimento bastante acelerado. Isto é expectável que nós, na terceira, quarta semana de abril, estejamos no pico e vamos crescer para um pico de forma provavelmente muito acelerada. Isto tem que ser feito com o planeamento de um plano de contingência em que tínhamos preparado sempre o nível seguinte quando estamos no nível anterior. E não será eficaz, certamente, se estabelecermos uma rede de trabalho entre nós sem que cada um de nós não se maximize internamente. A segunda lição organizativa que eu tirei, e que também é uma das minhas grandes preocupações, é que há absoluta necessidade de organizar áreas N1, de nível 1 de cuidados. Esta doença tem uma incidência também significativa no velho e na pessoa com comorbidades, e a medicina intensiva vai estar extremamente ocupada em lidar com o segmento de doentes mais críticos, portanto é importante que outras especialidades, necessariamente com o nosso apoio, porque vamos ter que comungar muito nesta batalha, organizem estas áreas N1 e N2 nos vários hospitais. Por este segmento de doentes que não têm indicação para a escalada de cuidados para suporte orgânico artificial invasivo e também para step down dos doentes que vão recuperando as nossas unidades. E a terceira lição organizativa, eu creio que é uma absoluta necessidade de reformular as nossas práticas na unidade, as nossas práticas relacionadas com a prevenção e o controle de infecção, entre doentes e também de manter a nossa equipa protegida. Todos vamos ser necessários e, portanto, é muito importante que tenhamos essas precauções de uma forma muito cuidada e que todos sejamos ajudantes do outro nesta batalha de não cometer erros, a investir e despir aquilo que é apropriado a cada momento, mas também ter um juízo muito relevante, que é uma batalha que não vai ser rápida e, portanto, também é uso inadequado, o uso excessivo de equipamentos de proteção. E, portanto, este juízo aqui adequado quer dizer um intervalo que está entre duas coisas más, que é usar de menos e usar de mais. Do lado dos cuidados e da terapêutica, eu acho que há muitas lições desta experiência. Uma delas é que vai nos exigir muito nervo e muito bom juízo e sensatez não abusar de antibacterianos nesta doença. Isto é, nós temos provavelmente que ir aprendendo ao longo do tempo e desenhar algoritmos que poderão ser apoiados em alguns biomarcadores, mas tem muito a ver com clínica também, de forma a não cairmos num abuso de antibacterianos nestes doentes e, portanto, será muito interessante até aproveitar este momento para desenvolver investigação nesta área e aprendermos mais sobre o uso desses biomarcadores. Depois, dizer que é uma doença que não tem provavelmente uma terapêutica específica, mas que há provavelmente tipos de fármacos diferentes que em segmentos diferentes no tempo e segmentos diferentes de doentes poderão ser utilizados. A maior parte deles são off-label ou experimentais e, portanto, eu também recomendaria que se aproveitasse este tempo para estudar, para perceber, para registar, não é que seja do ponto de vista observacional, quando não puder ser outra metodologia de investigação, mas é preciso que aprendamos ao longo do caminho de forma a fazer melhor no fim deste trajeto do que no princípio. Finalmente, do ponto de vista ventilatório, a clara percepção começa a ser sistémica nos relatos e na literatura, que há provavelmente dois tipos de doentes. Um que se caracteriza mais por um componente de mismatch entre ventilação-perfusão e de vasoconstrição descendente e que provavelmente não necessitará de pico muito alto e não responderá a ela e também não responderá à aprovação e em que provavelmente as regras de ventilação que usamos para o RDS normal não se aplicam tanto. E um outro segmento que isso sim, mais caracterizado por atingimento de lobos inferiores, em que a compliance dinâmica, ao contrário do primeiro segmento de doentes, aqui sim é baixa e que estes poderão responder à e à pronação. Outra mensagem muito importante é a necessidade de relacionarmos a decisão sobre o pulmão do doente com o que se passa na parte cardiovascular. Isto é, não levar as medidas de suporte ventilatório a um extremo que prejudique a dinâmica cardíaca, e nomeadamente a dinâmica do ventrículo direito, e, portanto, ter muita atenção à monitorização, seja por ecocardiografia, seja por parâmetros que usamos normalmente, como a saturação venosa central de O2. Talvez seja este o resumo que eu fizesse do que aprendemos com o Tommaso.
Obrigado, Zé Artur. Passo a palavra ao Filipe Froes.
Eu adorei esta comunicação e, sem entrar em muitos pormenores técnicos que o Zé Artur já referiu, o que me salientou e que eu gostaria de realçar é que esta história de nós pensarmos que isto era uma espécie de gripe foi completamente desfeita pelo Tommaso, e de nós pensarmos que isto só acontecia às pessoas mais velhas com fatores de risco também foi igualmente completamente anulada. Eu diria, perante toda esta comunicação, que todos estamos em risco, só que alguns estão em maior risco que outros, e provavelmente nós ainda não sabemos identificar bem esses que estão em maior risco. Também penso, depois deste cenário que o Tommaso apresentou, que o sucesso e o segredo do combate a esta pandemia provavelmente não está em adquirir mais ventiladores, não reside em tanta parafernália, mas sim num enfoque muito grande na prevenção. E é este o enfoque nesta fase que nós temos que realçar. Terceiro, precisamos de identificar precocemente as formas de gravidade e não atrasar tratamentos adequados de acordo com a gravidade. Estamos numa mudança de paradigma de ARDS, que nos vai obrigar a rever muito dos nossos conceitos antigos. E última e quinta conclusão que eu tiro: se há momento em que nós precisamos de colaborar uns com os outros e de uma coordenação, é agora. O momento chegou.
Só para terminar, então, eu concluo também, faço minhas as palavras do Zé Artur e do Filipe Froes, e acho que uma lição organizacional extremamente importante é que nós temos que nos preparar em nossa casa, ter equipas dedicadas a esta situação, começar já no alargamento das equipas, fazer treinos conjuntos, ensinar os diferentes profissionais, ganhar treino e rotinas de conjunto, e com isto feito temos que trabalhar em rede, temos que partilhar informação e tem que haver uma articulação que tem que ser centralizada. E isto porque nós vamos ter um aumento exponencial dos doentes em medicina intensiva, como esperemos que não, mas pode acontecer como aconteceu em Itália, doentes que são doentes muito pesados e que necessitam que nós antecipemos rapidamente os seus problemas, tenhamos uma estratégia de intubação precoce, de ventilação de acordo com o estado da arte, e que vamos ser guiados essencialmente pelo comportamento inflamatório destes doentes. Portanto, acima de tudo, acho que nós temos que preparar-nos nos nossos hospitais, nos nossos serviços e começarmos a trabalhar em rede a sério, porque nós juntos vamos conseguir fazer melhor trabalho. Para terminar, queria agradecer à Pfizer por nos ter albergado, alojado e facilitado a realização deste webinar, porque na verdade temos que estar todos juntos nisto, a indústria farmacêutica, os profissionais e todos os seres humanos que existem aqui em Portugal e no mundo. Muito obrigado.
Obrigado.
Obrigado.